I'd like to thank Oxford for inviting me to give my talk today. I'm no conflict of interest and a lot of acknowledgement for the work that we do that is carried out on the traditional, ancestral, and unceded territory of the Musqueam people. So my program focuses on precision transplantation, and it's called the Genome Canada Transplant Consortium, which we started in 2017 with CanPrev, and that was designed to minimize the rate of acute antibody-mediated rejection in renal transplantation initially, and use a three-pathway method to try to reduce that risk and monitor for adverse outcomes in transplant. That's then developed into something called CanProspect, which we were funded this year to do, which focuses very heavily on using nanopore on how to do this, and I'll go into some more detail in a second. And all of these steps are essentially leading us, hopefully, to the place where we can provide operational tolerance as a reality for our transplant patients, not just in kidney transplant, although that's where my data will focus on today, but anyone that is requiring either a bone marrow, a solid organ, or a stem cell transplant. So from 2017, what we noticed was that trying to match organs and allocate on a genetic level requires us to understand the HLA complexities of the HLA genes. I won't go into too much detail about that today, but the HLA genes are highly variable, most polymorphic region of the human genome, and have up to, I think it's at 40,000 variants right now. So genetically matching a patient to a donor, a random deceased donor that comes in the middle of the night, is just not possible. With using next generation sequencing, we were able to discern that these genetic sequences actually were more related to something called an epitope. So the HLA epitope is actually the key piece, the critical piece for immune recognition, and therefore an immune response could be mounted against the donor organ. And so we've published in this space to show that next generation sequencing provides high resolution typing that allows us to discern these epitopes, and we're moving forward into sort of immunogenomics and immunopeptidomics to understand the immunogenicity of these. So that's where we provided a computational simulation of whether or not having high resolution typing to allow us to map these HLA epitopes as opposed to the genetics would allow us to prospectively match a patient that is on the wait list to a deceased donor that comes in, say, at 3 o'clock in the morning. And so our simulations suggest that we could achieve a perfect epitope match, maybe not for all genes, which is the green line at the bottom, but for the key genes that are often seen when a patient develops antibody-mediated rejection. So if we look at the graphs on the right, the probability of achieving an excellent epitope match for DQ beta, a class 2 HLA gene that is often seen in antibody-mediated rejection, is almost 100%, irrespective of the patient waitlist size, which we modeled on the Canadian transplant waitlist. So knowing that this is feasible, that we could match using epitopes as opposed to genetics, we then needed to find a way that would allow us to map these epitopes in the time frame that we had for deceased donor workup. So if you have a living donor, which we also do, you have weeks and weeks in order to do this using next generation sequencing, which in our clinical laboratory takes about 5 to 10 working days. That's not a problem. But when you have a deceased donor, it comes in, you have about 8 hours to work that donor up. So offering that out with high resolution typing is just not feasible with short read sequencing, next generation sequencing. So we started working with Oxford and a couple other groups to try to get high resolution typing that is required for epitope matching for both for our recipients and our deceased donors. And so what we wanted to do was try to get this in about 6 hours that would then allow us to do the allocation. And then we only needed to do this at a low throughput, initially in a low throughput manner. One donor comes in at a time, and then we process that one, allocate the organs out. So what we showed initially is we did in-house validation initially, and then in Canada, unlike the States, and I'm not sure about the UK, but unlike the States, we actually try to standardize technologies and interpretation of clinical results across all transplant programs, of which there's 14 labs. And so what we did was, once the assay had gone to a level that we deemed was feasible, we then started asking other labs if they would like to test the assay. And so our phase 1 validation involved the first 6 labs across Canada using Oxford Nanopore to do rapid HLA genotyping to allow for epitope matching for their deceased donors. And in fact, this only took about 3 or 4 months to set up, and as of last week, the last lab in Canada is now Nanopore enabled, which means that all 14 labs and any transplant patient in Canada will now be able to be high resolution typed within 6 hours for epitope matching, which would allow them to have a better allocated organ and hopefully a better outcome. So this is just our data, not the national data, which if I had more time, I would present. But this just highlights some of the stuff that Clive was talking about on day 1. You know, over the 10 years, I've not been doing this for 10 years, but even just for HLA genotyping, which is very complex, from 2018 to 2023, our accuracy rates have improved, alignments have improved, the amount of data that we're generating is improving, and there's a significant jump in our mean Q scores. And this is obviously just a reflection not just of the capabilities of the technology, but also our understanding of the HLA genes, reference databases, and the different chemistries that have been coming through. But there's also going to be continual improvements, as I know that's been presented today as well. Another use that we've been using clinically is we have discovered novel genes. As I mentioned, the HLA region is highly polymorphic. The database is constantly being updated with novel HLA genes being described all the time. So using our next generation sequencing, we essentially identify 2 novels a month, new alleles that have never been seen. And these need to be processed and standardized and then submitted to the database to be reviewed. And so we published to say that although you can discover these using short reads, we've actually confirmed all 30 of our novels that we identified in the past 18 months using nanopore-based sequencing in a standardized manner, and then propose this as a policy for Canada, so that any other HLA lab, which are the main labs that sequence for the HLA gene area, if they identify novels, we would use the same platform and submit these to the database to be named as formal alleles in a unified format. So what other role does nanopore sequencing play in our program? So trying to get us to operational tolerance, that was the first step, which hopefully will be up and running, this year. We also use it for defining the the clonal and the transcriptomics of the TCR and the BCR repertoire that we see in these patients that are, immunosuppressed and once they're post-transplant. We also have other assays, including minimal residual disease. This is to look at how successful treatments have been post-stem cell transplant, for example. And other things that we've been looking at is trying to sequence the entire MHC regions, which I know has been done in previous publications, but this is in a clinical format, and how we would report these results, for the physicians to actually action. One of the other things that we've just submitted is to look at HLA-related immune adverse drug reaction genes. So most of the HLA labs also test for HLA genes that are related to adverse drug reactions that cause things like DRESS syndrome and SJS. So we actually have just submitted ultra-rapid nanopore sequencing to do this, and we can now report out in 4 hours to physicians who are wanting to prescribe a particular drug to a patient. They can now get a result of whether or not this patient is at high risk for developing adverse drug reactions to the drug that they're interested in. And normally this test would take about 2 to 3 weeks to get back, and by allowing this to happen in the same day, the patient doesn't even have to leave the office. They can just wait for a couple hours, and then they can either be prescribed the drug or be prescribed an alternative drug straight away. And just sorry, I'm very briefly, we've also started looking at rapid targeted sequencing and comparing this to optical genomic mapping for acute myeloid leukemia. And what we did was we were assessing standard of care, optical genomic mapping, and ONT to investigate whether or not we could use these for diagnosis of AML. We did this in about 10 to 12 I think we're at 15 patients right now, and we were able to detect all the variants. We had about a panel of 40 variants that we wanted to look at using all three methods. However, the adaptive sequencing was of most interest to us here. So the adaptive sequencing, like I said, was about 40 regions of interest in AML, and our most recent run, actually, we've achieved about 100x coverage of some of our regions of interest, which allowed us to detect VAFs of down to less than 10%, which is great. And we were able to identify all but one VAFs that were identified using short read sequencing. So that was a whistle-stop view of what we're using nanopore for in precision immunology. And I'd just like to acknowledge all of our collaborators and the team members that have helped me develop all of this assay results.
Thank you, Karen.